So this was a retrospective study that we conducted at MD Anderson Cancer Center. So we know that FLT3 is mutated in about 30 to 35% cases of newly diagnosed AML. Most commonly, this is FLT3-ITD occurring in 25% of the cases, and FLT3-TKD occurs in about 7 to 10% of cases. Now, while there's a lot of data on FLT3-ITD, its prognostic impact and how therapies work on it, there is very limited data corresponding to the same in FLT3-TKD. So that was the objective, to assess how FLT3-TKD AML patients do with current therapies, how do they respond to stem cell transplant, what is the impact of co-mutations and things like that. So we included about 124 patients in our entire FLT3-TKD cohort. And the first thing that we noted was that NPM1 co-mutation was very common in this group, occurring in about 44% of patients, telling that NPM1 and FLT3-TKD often co-occur together. We analyzed these patients then based on the type of therapy received, as intensive therapy and low intensive therapy. So looking at the intensive therapy cohort, we saw a composite complete response of around 80% with intensive chemotherapy in FLT3-TKD AML. When stratifying this by NPM1 co-mutation status, the response rates were much higher in NPM1 mutated AML, up to 100%, compared to wild type, which were about 60 to 70%. This actually was also seen to translate to a survival difference as well. So a median overall survival for the intensive FLT3-TKD cohort was not reached, with a 3-year survival of around 55 to 56%. The overall and event-free survival were both higher in patients who also had the NPM1 co-mutation compared to those who were NPM1 wild type. We also looked at how the addition of Venetoclax and FLT3 inhibitors in this era contributed to survival, and we noted that patients who had received Venetoclax or FLT3 inhibitors in addition to intensive chemotherapy had a trend towards improved overall survival compared to those who received intensive chemotherapy alone, though this was not shown to be statistically significant given the smaller sample size. We also looked at the outcomes of stem cell transplant in the intensive therapy treated group. And again, in patients who had the NPM1 co-mutation, we did not see a difference in overall survival between those who underwent transplant and those who did not. On the other hand, in patients with FLT3-TKD AML treated with intensive chemotherapy, those who did not carry the NPM1 co-mutation, they had overall survival benefit with stem cell transplantation. Next, we looked at the low-intensity therapy cohort, which also had a 44% preponderance of NPM1 co-mutation. So again, NPM1 co-mutation was pretty common. Among these patients, the composite complete response rates were about 60 to 65% to the low-intensity therapy. Again, the responses were higher in those who had the NPM1 co-mutation compared to those who did not. Looking at the overall survival outcomes, the median overall survival to the low-intensity therapy for the FLT3-TKD AML was around 11 months. Again, this was higher, up to 16 months in those who had the NPM1 co-mutation. Interestingly, the patients who received low-intensity therapy with FLT3-TKD AML who did not have the NPM1 co-mutation had a very poor median survival of only about 6 months, highlighting that this is a very high-risk group which needs to be focused on. We also looked at the outcomes of stem cell transplant in this cohort, and again, patients who carried the NPM1 co-mutation with FLT3-TKD did not show a survival benefit with stem cell transplantation, but there was a trend to survival benefit with stem cell transplant in those with the NPM1 co-mutation. So I think the biggest conclusion that we generate here is that FLT3-TKD and NPM1 co-mutations often occur together, and they need to be seen together to figure out the prognostic impact that they will have on the patient. The presence of an NPM1 co-mutation does generate higher responses and improved overall survival to both Venetoclax and FLT3 inhibitor-based therapies. And because their outcomes are so good, stem cell transplant doesn't seem to really create a survival benefit in this group of patients. On the other hand, FLT3-TKD without the NPM1 co-mutation seems to be a high-risk group, particularly when it's treatment with low-intensity therapy with a median OS of only 6 months. Transplant seems to help these patients and should definitely be considered in the first remission. Thank you.